Good evening. My name is Vernell Branch, and I am a 20-year breast cancer survivor and patient advocate. And I am here to interview Dr. Kate Lathrop. And welcome.
Thank you. Thank you very much. I'm very glad to be here.
You know, this has been an exciting week. We're here at San Antonio for the Breast Cancer Symposium. Today, what did you find very compelling about this meeting? Was there anything there that came out at the meeting that you felt was very compelling?
Yes, there were actually many really good poster presentations and podium presentations this year. But today, one thing, the big focus today was on a subset of breast cancer called HER2 positive breast cancer. And there was multiple different presentations today regarding how we can treat breast cancer that has HER2 receptor positivity, right, and how we can maybe do it smarter. Mm-hmm. And those presentations ranged from how do we treat women with very small, early breast cancers that are HER2 positive, all the way to women who maybe have larger breast cancers or have nodes that are involved with the HER2 positive breast cancer. Just this afternoon, we heard a very interesting report out of the Netherlands. A group of physicians there went back and they looked through the national database, and they particularly looked at a group of women that we don't have a lot of information about. And it's a group of women with very small breast cancers without the nodes being involved. And we call those stage 1 breast cancers. Okay. So women with stage 1 HER2 positive breast cancer, we don't have a lot of data or studies to guide how we treat those women. So currently, if you look at the guidelines that are published by large societies that review all the current research, for women whose tumors are about less than half a centimeter, we don't generally give those women chemotherapy, and we don't generally give those women the antibody type therapies like trastuzumab, or the brand name is Herceptin. So this study looked specifically at those women. It looked back between 2006 and 2012 at this registry that they have in the Netherlands. It included over 3,000 women, so quite a big population. And some of those women did get chemotherapy and trastuzumab, and some did not. Okay. So they were able to look and see over time what happened to those women who got treatment versus the women who did not get treatment. It was very interesting is that the women who, even if they had very small tumors, who got treatment with chemotherapy and this trastuzumab, right, they had a better breast cancer specific survival. Okay. And that was for very small tumors, which we call T1As, okay, which are less than half a centimeter and up to 2 centimeters.
So the overall survival was better for those women.
That's correct. And okay, over those 3 different categories, it was about on average 5% better. So that sounds like a very small number, but for women who can potentially have a recurrence of a very aggressive breast cancer, that's something that a lot of oncologists are going to be taking home and talking with their patients about now. Now that we actually have data, we can have that conversation with the patients and say, this, based on these numbers, this is the potential benefit of giving chemotherapy and trastuzumab. So there's certainly diversity within that group. Some women are going to be younger. They're going to potentially have more aggressive tumors even within that subtype of HER2 positive breast cancer. Some women might be older or have other medical problems. And so it's always an individual conversation with the patient and their physician about what is that particular patient's potential benefits versus the potential risks of those treatments. And you have to balance those two things together.
So as a physician, what would you do in a case like that, where you had an older woman who also had the same types of tumors, small tumors,
sure,
T1, and would you treat her with chemotherapy and trastuzumab? Say if she was 65 years or older.
Yeah.
What would you do? What
65
would you look at?
years and healthy and no heart problems, which is something we particularly look at in that type of treatment, I would really seriously consider talking to her about it.
Okay.
And the type of chemotherapy we would potentially maybe pair with this combination is called a taxane, something like paclitaxel.
Okay.
So it would be potentially a single agent chemotherapy or maybe 2 chemotherapy agents combined with this Herceptin. So it's, what this data has given us is more information about a group of women that we before didn't have a lot of information about. And so now potentially we can make better decisions with our patients.
Okay.
So it was exciting.
Sounds really great.
Yeah.
Sounds really great. What are you going to do next? What are you going to take back to the clinic when you go back to your office on Monday?
Yeah.
And how are you going to start treating women with some of the information that came out at this meeting?
Well, certainly I think there's going to be a conversation not only in my clinic but in clinics around the United States and maybe even the world about how we treat these younger women with HER2-positive breast cancer that's very small and found early on. Another conversation that I think is going to be happening is what type of imaging we should be doing for our patients.
Okay.
There was a abstract presented this meeting about whether doing more in-depth mammograms called tomosynthesis is a benefit or not.
Mm-hmm.
So there's going to be some more discussion about that and how we diagnose these women with what we consider plain mammography versus tomosynthesis.
Would this be for high-risk women or women who you've been screening because of family history and because they're BRCA 1 or 2?
Right. This would be for both,
Mm-hmm.
but also for screening. The most common imaging that we do is screening mammograms.
Right.
So for women who are particularly high risk, we already sometimes pair things like MRI, and that's somewhat standard. But
Mm-hmm.
this would be addressing the biggest population of women, which is screening. We also heard some more information this meeting about using a type of medicines called aromatase inhibitors, which is a type of hormonal-based therapy for women with a very early stage breast cancer, which is called DCIS, or ductal carcinoma in situ.
Right.
And we heard 2 abstracts presented today that support using aromatase inhibitors in women who are postmenopausal who have DCIS. So there was a large study that we had information already on, which was called NSABP 35, which showed that you can use aromatase inhibitors instead of tamoxifen, which had been the standard of care for years and years for DCIS. Now we also have the ability to use aromatase inhibitors. And one of the important things about that is those have different side effect profiles. So again, when you're trying to have a conversation with your patients about the benefits and the risks of therapies, or the benefits and the side effects of therapies, having 2 different medicines that you can potentially offer that have different side effect profiles could be really potentially good for the patients.
Do you look at the patient's comorbidities, if they have any,
Oh, yeah.
before you prescribe these AIs?
Absolutely.
Okay.
So tamoxifen has its set of pretty well-known established side effects based on the way that the medicine works in the body. And likewise, aromatase inhibitors have a very well-defined set of side effects,
Okay.
Also based on the way that the medicine interacts with the body. For example, tamoxifen can increase the risk of uterine cancers. That's well known. And maybe potentially, and this hasn't been studied very well, a slight increased risk in ovarian cancers. So when you're talking to women who may have family histories or a particular concern for that, you may want to stay away from that in the tamoxifen group. Likewise, aromatase inhibitors have more side effects on the bones. So it can cause more osteoporosis or thinning of the bones, which is osteopenia. So women who already have thinned bones or have had fractures or a family history of osteoporosis, you may want to stay away from that medicine or do things up front to try to mitigate that risk.
Okay.
So having two medicines instead of one's always a good thing.
Okay. But you said it was for postmenopausal women.
Yes.
What about the premenopausal women?
Premenopausal women, we're still using tamoxifen.
Okay.
Yeah.
All right. Okay.
Yeah. The other medicine doesn't work in premenopausal women.
Well, this is an exciting time for breast cancer, I think.
Yes.
And because this is the largest breast cancer meeting, I think a lot of more things come out of this meeting that is going to really change how we look at treating our patients. You're treating patients.
Absolutely, and to piggyback on that idea that this is the largest breast cancer meeting in the world, I think we had somewhere around 90, maybe more, countries represented here, and more than 7,000 people came to this meeting this week. One thing we did that was new this year was we had a session on Tuesday, which is generally reserved for our education sessions. We had a session earlier in the afternoon that was looking at how you treat women with breast cancer in countries that are, we consider, more underdeveloped.
Right.
And so, you know, we have all these amazing therapies that are coming out, and most of them, unfortunately, are very expensive, and a lot of them do take physicians that, you know, have the luxury of specializing in oncology. So not only do I specialize in oncology, I get to specialize in breast oncology, which, you know, a lot of physicians around the world, they don't have that ability. They, you know, they're underserved areas, they have to be more diverse, they have to treat more types of diseases. And so a big question for us in the United States and some of the other more developed countries is how do you deliver that care to women in underserved, you know,
I see what you mean.
more depressed countries.
So how can we assist those physicians to bring what we have here in the United States and other countries, developed countries, to those underserved communities?
Yeah, how can we assist, but also how can they assist each other? So what we did was we had 3 physicians, one from India, one from Saudi Arabia, and one who's currently in France, but is from Colombia, and they gave presentations on how they deal with individual problems in their own countries and underserved areas. So you can, since we have physicians from 90 countries coming here, those people can share their experiences and how they best deliver, you know, the best standard of care in their areas. And a lot of times those are transferable not only to underdeveloped countries, but honestly to, you know, South Texas as well, because we struggle with that too
you
here.
Have a rural community.
Oh yeah, we've got a lot of the same, you know, when I was listening to the session and they were talking about their challenges, they have women who culturally don't feel empowered, they have women with language barriers, they have women who are economically depressed within their communities, and you know, those are a lot of the same problems we face, you know, in parts of San Antonio even, and down into South Texas and Mexico. So, you know, hearing how they deal with that on a large scale, we can take that and translate it here to our, you know, underserved populations too.
Well, that sounds terrific, and I know that you're going to try to make that happen.
We do. I
thank you
for
letting
you.
me interview you, and just
it's
keep
a pleasure.
up the good work.
Thank you. You too. You too.